pre-hospital airway management. I guess the headlines for this are going to be assessment of the airway, thinking about maneuvers of the airway, thinking about adjuncts you might use to employ to either aid the opening and patency of the airway or indeed secure the airway. But then the final thing we'll talk about, which is completely different in pre-hospital care and management of the airway, is planning. So thinking ahead to the next stage, the next arrival of crew, the next part of the journey for the patient, or indeed anticipating how you might gain help should a certain intervention or a deterioration not go as you'd hoped. So coming to airway assessment first, it's look, listen, feel. So looking at a patient, I can see that they're ventilating or not ventilating. I can see if they're in respiratory distress or not. If I look down at the airway, I can see any obvious signs of injury to the airway, swelling, hemorrhage, detritus, soiling the airway at all. And then I can come in close, and if I'm opening the airway, look into the airway, either with the aid of a torch or just natural light to see if there's anything obviously obstructing. That may be the patient's own anatomy, there may be tongue obstruction from reduced level of consciousness, or swelling from a medical cause. There may be teeth in the airway, dentures, or materials that have resulted in entry to the airway from trauma. So having eyeballed the airway in the patient, I can listen. I can get down close and listen for those sounds of obstruction. So that may be stridor, the sound of a narrowing airway, a high-pitched inspiratory noise generally, or it may be stertor, maybe that snoring noise that we're all familiar with the sound of our partner lying next to us in bed. And that's something that we all do if we get unconscious enough. It's positional, it's anatomical, and in most patients, it's survivable, it's correctable, and it's something we can do something about. Finally, you can consider feeling, and by feeling, I mean both feeling the rise of the chest, feeling the breath on the side of your face, any other indication of effective ventilation. So now that we've assessed the airway, we have to think about whether or not it's threatened, whether it's secure, and whether or not we want to do anything to improve things. So looking at positioning here, Alicia has very kindly become unconscious in the recovery position. This is your default sole rescuer position. This is someone who's got an airway that, should she vomit, is unlikely to aspirate, someone who's in a relatively stable physical position, she's in reasonably anatomical alignment, and she's not moving anywhere with just simple assessment just now. So this is a pretty safe place to be for the airway. If my assessment said her airway was obstructing, we would need to move on to do other things. Each of those things is harder in the absence of a team, and for the purposes of this tutorial, we're going to talk about interventions that may require added people to help you out. So say we needed to go on and do maneuvers to hopefully relieve obstruction. The best way of doing that is in the supine patient. So if Alicia can comfortably become unconscious on her back, this adds a certain issue because that anatomical obstruction, that tongue and soft tissues of the pharynx, are now going to head posterior and cause obstruction. So our interventions, our airway ladder if you like, are likely to be aiding the bringing forward of those structures. Of the head tilt and chin lift of the hopefully mildly opened airway and seeing if that improves things, or the generally more effective but harder to do as a single rescuer, jaw thrust. So fingers squarely behind the angle of the jaw and thrusting directly perpendicular to the line of the patient. And that's something that's incredibly painful in the conscious patient. Thankfully we've heavily sedated Alicia just now. It's also something that by default, if you're applying a bag valve mask, is much easier to do over a well-inflated bag. So pushing down across the face and up with your fingers to get that good seal, but also good jaw thrust. Moving up our airway ladder for remaining obstruction, our maneuvers have not aided things, it may be that an adjunct is a useful addition. Now, we've got a bit of an airway ladder sitting here in our pack, as you can see. It may be that the adjunct we need is something to remove a physical obstruction. Now, that may be suction, which should be done ideally with a laryngoscope, aiding visualization and direct view of what you're taking out. Mechanical obstructions can be removed potentially with a McGill's forceps, And this is something that allows, again, direct visualization, grasping of the item. They're blunt-ended. You should be able to see what you're taking out and removal thereof. That may be foodstuffs, blood, clot, teeth, dentures, what have you. Now, if patency is still an issue because of those soft tissue structures, it may be that moving on to an oropharyngeal airway, a Goodell, is a good starting point, and certainly for the deeply unconscious patient, such as Alicia is, that's a good starting point to go for. This is something that we can size, looking at, hopefully, running from angle of jaw up to the front of the mouth. We can see that this is too small, and we can see that this may be just right. So how are we going to do this? We're going to open the airway, we're going to bring it down across the back of the tongue and in, either in a one-way motion, or potentially it may be easier to bring this in upside down, trying to get past the tongue and then flip halfway and all the way down. For all these interventions, maneuvers, adjuncts, we're going to test ventilation after each one. If we've made things worse, our plan B is to go back to where we were before. A nasal airway, a nasopharyngeal airway, is something that's going to, again, try and get past the tongue. In the pre-hospital environment, it's likely to cause bleeding. You've got someone who's deeply unconscious, unable to tell you that you're pushing on something. You've got someone who's already sustained trauma to the face potentially. So it's incredibly important to do this lightly. Ideally, you're going to get something that looks to be the same size as the nares. So in Alicia's case, I think it'll be this fella. We're going to come in the right nostril preferentially, and we're going to lubricate the end of the tube, come down directly perpendicular again, go immediately posterior and pass the tube down until we reach a point that we can secure to the lip of the nares. Again, test the ventilation, see where we go. Now, should the airway be requiring more support and should they be requiring more effective ventilation, moving on to a supraglottic airway may be required. We carry the iGel. It doesn't require inflation. There are LMAs that would require an inflated cuff. The iGel is a spongy, flexible, shaped to the back of the posterior pharynx device that should be able to advance directly down in the midline, potentially held like a pen. And if I open the airway over the tongue and all the way back down to sit in the immediate posterior pharynx, and then trial of ventilation. And that usually provides a partial seal, but does not prevent aspiration. Finally, to secure the airway, it may be that the patient does require pre-hospital intubation. That's only to be undertaken by those trained in the skill, and ideally with at least one assistant to aid them in the process. Laryngoscope, ET tube, syringe to inflate the cuff, and then finally hook up to your bag an oxygen supply. Again, ideally confirmed with capnograph tracing so that you can see that you are getting CO2 back up the airway.